The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, and we have something really exciting coming. Our very first white paper, a paper developed by a group of experts on an area where there's some controversy, this specific area being myocarditis, and the white paper dealing particularly with the role of cardiac magnetic resonance in myocarditis. And I'm speaking with Matthias Friedrich, who's the director of the Stevenson Cardiovascular MR Center at the University of Calgary and was the chairman of this committee. Can you tell us a little bit about the group that was assembled and how you went about creating this document?
Yeah, it was exactly 3 years ago that we gathered a group of about 20 experts from Europe and North America, experts either because they published on cardiovascular MR and myocarditis, or because they were experts in myocarditis, such as pathologists, molecular biologists, but also clinicians. And over the recent 3 years, we developed these criteria.
Yeah, well, that's certainly a group that's qualified to comment on this. One of the problems with myocarditis is the gold standard. How did you deal with that in relating your MR criteria?
That's indeed a difficult issue, and we had a lot of discussions about that. The way we tried to deal with that was that we used combined criteria with clinical criteria plus immunohistological criteria, or combined clinical criteria as they were published during this time and the period and the time before, and only considered controlled papers with using these criteria as eligible for being evaluated for these recommendations.
And what were the criteria you found to be best, Matthias, and how accurate are they?
CMR provides a wide range of potential diagnostic targets, but based on the literature, we decided to use three main criteria, two of which mainly address inflammation. One is called the early enhancement, which quantifies the gadolinium accumulation after contrast administration over the first 2 minutes after the injection. The second criterion addresses the edema and is visualized by T2 weighted imaging. And the third one addresses the irreversible injury or scar or necrosis induced by the inflammation. That's the late enhancement. And we found the diagnostic accuracy was highest if we used two out of these three criteria as evidence for myocarditis. And using this criterion, the data as we have them right now allow to get a diagnostic accuracy of 78% and a positive predictive value of 91%, although the negative predictive value is 67% only. But that's probably still better than anything else we have out there for diagnosing myocarditis.
Right. So you see it used not only for diagnosis, but to follow patients and for prognosis as well? The
data on that are still pretty scarce. We have evidence that both inflammatory markers, edema and early enhancement, disappear over a period of about 4 weeks, and these data have recently been confirmed by another paper in JACC imaging, whereas the late enhancement, mainly showing the irreversible injury, usually stays. And the amount of inflammation about 4 weeks after the onset of the disease obviously may be a good predictor for long-term outcome in terms of functional recovery and clinical symptoms.
Well, we certainly need help in dealing with our patients with myocarditis, a way to diagnose and follow them, and it sounds like MR may well provide a great deal of that help. We'll be anxious to look at that white paper because it clearly comes from the individuals who are best positioned to do this. Thanks very much for being with us.
Thanks for having me.